Alrighty. Shall we introduce ourselves?
Yeah, why not? You kick off.
Okay, I will indeed kick off. So my name is Isabel. For those of you who know me, quite a few of you, I imagine, will. I am a fourth year waiting to graduate, currently working in renal, and I will be starting my FY1 placement in Birmingham, which is West Mid Central Deanery.
I'm Dean. I've met a few of you before, and you might have seen me around. I'm also final year, exactly the same, waiting to graduate essentially. I am going to West Mid Central as well, weirdly, and I'm currently on as a kind of COVID rest gen med weird hybrid thing. So yeah, so happy to answer any questions about that as well.
Yeah, anything really. We'll put our emails in the chat so that you can feel free to contact with us with anything. And I guess obviously you're like a very, very stressful time. I can imagine you guys are feeling quite stressed with regards to kind of fitting everything in and making up all the time you need for your GMC requirements. So, well done for coming, well done for everything you're doing. And just try and take care of each other and stay motivated any way you can, really. Naps are good.
All right. So kind of the purpose of today is just to give you a rough overview of the SJT and kind of give you some advice. Obviously, we can give you hints and tips of what we found useful, but we even might have differing opinions of what worked and what didn't work. I think if you spoke to 10 different people, you'd get 10 different answers about what worked for them. But just a general overview. And at any point, if you've got any questions or queries, just let us know. So we'll get started if that's all right.
Crack on.
I'm working out teams.
Okay, so SJT, you'll sit this in December, nicely before Christmas. So the SJT, oddly enough, it's the biggest single factor in determining what foundation school you get into, and where you probably have kind of like a vague idea of how what the SJT is. You might even know like a little bit. You might have done some research on it, but it has more bearing on your final educational performance measure than your any previous degrees, any publications, or any decile. So if you may be a bit worried about where your decile is going to be, or extracurriculars or things like that, the SJT is a thing that kind of can bump you up to where you want to be. It's a very long exam, but it does fly by. It's 2 hours and 20 minutes. And you've got both ranking questions, so that'll be like you'll get a scenario. You've had these in CBL, I have no doubt. I seem to remember that we did. Yeah, you'll have the scenarios where something's happening. Here are 5 responses, rank them from most to least appropriate, and you also get selection questions. So here's the scenario: which out of these answers are the 3 most appropriate? Okay. And here are just some examples of those ones. So on the left, you've got your ranking question, and on the right, you've got your pick 3 questions. So you get more on the pick 3 questions because they're considered to be easier. So you get a few more to pick from, and then you just get A to E on the ranking questions.
And we've got some examples to go through with you later, so don't worry too much about kind of desperately trying to read this one at the moment. So I think it's quite a good idea just to go through how the SJT scored. You'll be able to find lots and lots of information about this on the Foundation Programme website, and I suggest you get familiar with that, read through the SJT FAQs, and just kind of really understand what it is that they're testing, what it is they're looking for, and also how they mark it. So your ranking questions can give a maximum of 20 points. And basically, I don't know if the next point makes sense, but hopefully the picture after I'll show you in a second will. So each ranking is given an individual score up to a maximum of 4. So if you get each answer in the right order of the 5 available, then you get 4 for each of those, so a maximum of 20. If, for example, you are 1 out, you'll receive 3 out of the 4 points. If you were 2 out, you'd receive 2 out of the 4 points, and so on. So basically, the idea is that if you focus on getting your first and last preference in the right order, then actually your middle ones, although are still important to get in the right order, have a less detrimental effect if you were to be 1 out, for example. But if you were to get your first and last the wrong way round, then you could in theory get 0 and drop points quite quickly. So it's just good to have that in mind. And then this just shows you that as an example marking table. So you can see that if you rank it as number 1 and the ideal rank is number 1, then you get 4 points. But if the ideal rank is 5th and you rank it as number 1, then you get 0 points for that. So it's important that you get those 2 right. Sometimes it's very obvious what the most appropriate answer is and what the least appropriate answer is. And the middle ones can be a little bit tricky. However, I found, and I don't know if you agree with this, Izzy, as well, but on the real exam, a lot of the ranking was very similar, and it was quite difficult to differentiate between even the worst and best answers, let alone the middle ones.
Yeah, there were a few where the SJT test kind of, you pick the most appropriate one, but also there's like an air of immediacy in there. So I found at times sometimes what I would think was the most appropriate clinically wasn't actually the most immediate thing, and therefore that the most immediate and appropriate thing would have been number 1 rather than what I would be like, that's my default answer. Yeah, definitely.
So
okay, so the SJT, I think people get very, very het up about it because it is such an important exam, as I've stressed before, but it's kind of, you need to strip it back to what would you do in real life. So if you had a problem with the behavior of someone who would you talk to first? Would you talk to someone above them? Would you talk to them personally? If you had a problem with the course content, would you talk to the person who taught you the lecture you didn't like? Would you go straight to the person who's in charge of your year, in charge of that block if you were in year 1? And if you had a problem with workload or your learning, would you talk to student support? Would you talk to your CPT? It's worth thinking about things like that because a lot of the questions will deal with how well you escalate. So thinking about, if you have a problem on the ward, there's no point emailing the whoever's running the foundation course. You want to talk to your consultant at the time, you want to talk to the nurse in charge, etc. So they want to see mainly kind of how well do you handle difficult situations? So can you prioritize things in the order that they should be done? Can you escalate to the right person without going over their head or dealing with something that you aren't equipped to deal with? Can you work within your competence? So you do have lots of questions about, getting home on time, having a really heavy workload, things like that. And all of the skills it's testing you in, even though it's a bit of a bizarre thing after years of finals, which are very knowledge based, to have something that's basically just ethics questions. It tests how well you're going to be able to cope as an F1, working independently, knowing when to say that you're out of your depth, knowing when to hand things over and go home, and knowing who to ask for help when you need it.
Yeah, and the questions are written in a very specific way, and they are only detailing that situation that they're describing. So they've very purposefully put in the information that is there, and they've also very purposefully not put in the information that's not there. So don't start coming up with your own theories about what this is suggesting. Go with what is written in front of you and only with what is written in front of you. Because otherwise, I think when I was practicing, I found that I was like, oh, well, actually, this could be going on. And then what about that? But stop that because it will get you into kind of sticky situations, really.
Yeah, don't if you think that the diagnosis is different from the thing in the question, don't try and re-diagnose it. That's not what the SJT is there for.
I should have put this before, really, actually, but it's in there at this point now, so you can have it here. So overall, the SJT score, I think it's key to remember that if you walk out not knowing how well you did, then actually that's fine, and that's kind of the point, because you don't know exactly what the answers were. The way that the questions are set and the way that the answers are set is that the panel will come up with what they feel is the most appropriate order at the time, and it might be that actually if you had another panel, it might be a slightly different order. And for some of the questions, you could argue every single answer to be the most appropriate. So you will come out feeling a bit flustered, feeling like you don't really know what's happened, but that's completely normal. And I think it's important to know as well that whilst most of you won't, and I doubt that any of you watching this will, it is possible to score 0 in the SJT, and it is also possible, and some of you may score 50. So only one person can score 50 and only one person can score 0, and then every single person is then put on kind of each score in between that. So your score will go down to like 3 decimal places. However, most people will still score around 40. So there's very few people that score very low scores, I think less than 1%, and about 2 to 3% score very highly. So the way that it's modelled is based on how well people perform in their EPM, so their decile rankings and previous publications and degrees. And then it's also scored on how well, as a cohort, the entire 26, well, not 2016, but how everyone over the years from all medical schools perform in the SJT. And those two are used equally so that both the EPM and the SJT have equal weighting. They will release the equation that they use after, so that you can work it out, but you won't be able to work it out before. It's a weird like adding and multiplication and taking away that you just won't be able to foresee, and it's based on each year independently. So but I think it's just important to know that there are that possibility. If you do score very low, then you'll be invited to an interview to basically prove that you're safe to work in an environment. And sometimes what it is that people have just not noticed how to record on the sheet properly. So get familiar with how to use the pencil marking and using the ranking. You'll get given nearer the time lots of things on the foundation program website, and I recommend downloading the past papers and using the actual sheet, because it's a very time pressured exam, and it's useful to know how that works. The link I've put in here as well, I don't know if many of you've seen it, but it will allocate you a score based on your average for your medical school. So Warwick traditionally does very well in the SJT, and you can put in your decile, you can put in your previous publications, and it will give you a rough estimate of where you may or may not be accepted into based on previous minimum scores for that deanery. So it's just a nice way of having a rough idea of where you could apply for. So if you wanted to have a look at that, it's quite a useful little website.
Yeah, I just want to reiterate before I share my top tips what Dean said about the exam being time pressured. I said it's 2 hours 20 minutes. I answered the last 15 questions in 15 minutes, just going on, like, reading it and answering very quickly, because some of them do bear thinking about, and that does slow you down. So getting to grips with the timing, getting to grips with using the answer papers is really helpful so that that doesn't happen to you. I mean, it didn't do me any harm in the end, but I actually found in final year full stop that I had less time for all of my exams than I thought I did. So I think I'd gotten a bit complacent in previous years and slowed down a bit. So definitely worth getting used to using the papers. So my top tips. As we've just said, Warwick students tend to score quite highly, and that's possibly because you've got a higher average age than a lot of graduates. So they won't have had exposure to things like doing other jobs, so interacting with other people in a workplace and all the politics and things that go along with that. More clinical exposure. You get bedside teaching quite early on in year one, whereas, you know, even Oxford, Cambridge, places like that will have preclinical years and go from there. So that shortens your time. That's not to get complacent, but that is to say, you know, have some belief in yourself. Your life experiences thus far will have prepped you for the SJT. And if you think all the way back to UK-CAT, you will have had some exposure to kind of the ethical questioning that they use. So not to get complacent, but that's just there to think about. My second one is climb the ladder, because it helps me to think about things logically. So how would you address a problem with a person you're working on war with? So say you're an F1, you've got a fellow F1, you've got a problem with them. Presumably your first point of call would be to talk to them. It doesn't feel nice to have someone talk to someone over your head before you've been addressed correctly. So the best thing is to do is to climb the ladder. You start on the bottom rung with the person who's involved. Then say you're on the ward, you could go to their reg perhaps rather than the consultant. A lot of people are more comfortable with their regs. Then you can go to the person above that, who's the consultant on the ward, if this is a ward-based problem. And then you could head to the person above them if nothing's changed, like their educational supervisor, for example. But if it's something maybe more emotion-based or workload-based, or you're worried about them, their educational supervisor would be the first port of call. So think about, in these situations, who's the first person and then who's the next logical person that will get the problem solved most quickly. Because in the nicest way possible, telling your consultant about your mate who's an F1's emotional problems is not going to be the best choice you could possibly make. And then finally, we're going to talk about the kind of the document this is based on shortly, but what makes a good doctor and how would you expect them to act? So the answers do want you to be polite and professional, good at prioritization, and good in working in an MDT. So they will have those questions that try and trip you up into being like, well, I'm the doctor, I know everything, nurses don't know anything, HCAs don't know anything, which, as we all know, is complete and utter nonsense. But there'll be questions like add that in there. So polite, professional, seeking information, what's most important needs to be done first. But a lot of the questions are about recognizing when you need help. At this point, something like, say, an upper GI bleed, you're thinking, oh, I would put out a major hemorrhage protocol call, maybe. I would think about starting them on some omeprazole, maybe some terlipressin, things like that. There might be things that you've learned that you think could apply in this situation. But if someone starts vomiting buckets of blood, probably the first thing you should do is be like, help, someone is vomiting buckets of blood, please come and give me a hand. So recognizing when you need help, even if you kind of know what the theory is, even if you think you could have a good stab at it, just recognizing when it would be safer for the patient to ask for help. And patient safety is going to be what underpins the answer to every single question.
Okay. And then I think my top tips would be to practice, but not too much. A lot of people said this to me before, and I was like, why would you say that? This is literally one of the biggest exams I can sit. Of course I want to practice, but actually, after doing it and looking at most of the literature that's out there and the practice books that are out there, it's a lot of rubbish. I thought the Oxford Handbook would be a very good representation of the real SJT, and it was probably one of the worst books that I looked at. It didn't represent the standard of questions in the final SJT paper in any way whatsoever. I personally felt, and a few others I know felt that as well. It was very oversimplified. The real SJT has very long stems. options are very similar to one another, and you really do have to think about it. So I found that by doing the other books, it was maybe a good thing to do like a few months before, but actually nearer the time it only confused me with what they were suggesting, as sometimes I found that it went against what the SJT practice papers were suggesting. I'd also say the SJT practice papers are the best things that you can use. So they'll give you access to 2 papers a few weeks to months before the SJT. I found just doing those over and over and over again was the most useful thing to do, and that helped me. However, they still aren't that good representation of the real SJT, and for whatever reason they don't seem to let you into that hell until you finally enter the room. Patient safety, we talk about it a lot at medical school anyway, but basically patients are first in everything, and I've put in brackets except when they aren't, only because there's a couple of times where you might have to do something that kind of goes against the patient. So for example, if that patient was at risk at harming others, or if you were to inform them of something, it might induce more harm. So, but for the most part, if there's a patient safety element to the question, more likely than not, that's going to be one of the right answers. But there were a couple in the practice that tripped me up, and I was trying to find it as an example, but I couldn't find it going through my stuff. So, and also don't overthink it. I think, as we were kind of alluded to earlier, that if you read that stem enough times, you can convince yourself of any single eventuality, and then you start to kind of fill in the blanks for yourself. And all of the answers there, in a way, can be correct, apart from the ones that are clearly not. So there'll often be ones that are really, really obviously wrong, and it will be like, have a go at the patient, or start talk about the nursing staff to your colleagues behind their back. They're clearly very wrong, but for the most part, most of them can all be correct. So yeah, just kind of go with your gut if you can.
Yeah, so just before we go on to good medical practice, had a question from, do you recommend any practice books? I think we gave you a little bit of an answer there. From my point of view, I didn't use any because I think the books age very quickly with regards to kind of how you should answer the question. I did use the SJT section of PassMed, which I found very helpful, but the questions on there are still different from the real thing. So those, I used PassMed up until about a couple of weeks beforehand, and then I did, I think, 1 paper a week, and that was all I did.
Yeah, I think they're good to get a gist of things and to as a starting ground. But yeah, I agree. As you get nearer to the time, get rid of them. Just use the practice papers, because they are set by the foundation program. They give you what they're expecting. PassMed is written by other people in the same position as yourself. So I wouldn't necessarily go with those as my first choice. However, I did use it, and yeah, but I wouldn't use it as a be all and end all. Would you agree with that, Izzy?
Yeah, absolutely. And I'm pretty sure the papers have questions that have almost the same stem to PassMed, but the answers are different. So
Yeah.
again, it's the thing, like, so in our actual finals we had questions which were ripped straight out PassMed and were exactly the same answers on the website. In the SJT, same stems almost, but completely different order.
Yeah. So good medical practice. I hope that at least you've seen this. Whether you've read it cover to cover, it doesn't really matter. I would recommend printing it out, going through it, and having an idea of what's in it. It was last year for us. I don't know how you felt, Izzy, but I felt like this was treated as the Bible of the SJT, essentially.
Absolutely, yeah.
You have to know it inside out. But I kind of read it expecting my mind to be filled with all this information about the SJT. It's the vaguest document that you can lay your eyes on. It's very short, but it does provide the basics that you need. And so if you get stuck, you can refer back to it, but don't expect it to be the holy grail of your SJT woes, because it certainly is not the case.
It's very, the GMC can be very kind of uses like the word should rather than must, or is kind of a bit woolly about whether or not you should do something. So in that way, they're not very helpful, but that is what they base the questions on.
Yeah. And remember as well that the SJT is based on what you should do, not necessarily always what you would do. So kind of before you answer, think, is this what I should be doing? And that's always kind of a good fallback as well.
Yeah, it's like a TZOC, I think, you know, when you first learn to take blood, they're like, you would never take blood with a syringe, and I think anyone who's worked on an elderly ward knows that. I mean, I'm on renal, I do nothing but take blood with a syringe. It's the same. It's doing, you know, it's the pro forma of it, and the performative aspect of it, and that will get you the marks.
Yeah. So we've got some practice questions now. I've taken these from the practice papers that we were given for our SJT. So I've purposely not put too many in, because just in case they're recycled for your year next year, I don't want you to kind of see loads and loads, because I don't think that would be very helpful. But before we start those, has anyone got any questions or things that they wanted to go back over, or is there anything that you feel that we haven't answered yet?
How long should we? Oh, here we go. How long should we be preparing for? Oh, I don't think I prepared for maybe more than like month and a half.
Yeah, not long. When I was in your position last year, I was like, I'm going to be preparing for like 6 months, definitely August. I'll be doing practice questions all the time, and did I hell? Just literally a couple of weeks is sufficient. You'll see some courses that you can go to as well. Some people swear by them, some people don't. I didn't bother.
Yeah.
And
I know someone who went to one of those and scored very poorly and thinks that's why.
Yeah. So I didn't go. I just used the practice questions, and I scored very highly on the SJT. And I wish I could sit here and tell you exactly how that happened. I can't, so I'm just giving you the basis of what I did, and hopefully it helps you too. But
yeah, and then we've got a question said, there's a rumor about red flag questions which fail you. Is this a thing? I'm sure that's not a thing. I've never been aware of that big thing.
I've never heard of that rumor.
Oh, there's new rumors this year.
Oh,
No.
no, I don't think there's red flag. There's practice questions. So there's questions that don't score you, and they put in to see how people respond to them, to see if they can be used for the next year. So I think there's 10 questions that are like dummy questions, but you don't know which ones they are.
No, and don't try and guess which ones they are. I think in our one, do you remember the weird one about CPR in the ambulance? I think that was probably a dummy one because it was so mad. But like you absolutely can't game and guess which ones are going to be the dummy ones. You're equally as likely to pick one of the ones that are actually relevant as the dummy ones. But no, to my knowledge, there's no red flag question that will fail you.
I don't see how, because it's so the SJT is not an exam that you can technically fail.
Yeah.
So in theory, if everyone does fantastically well in the SJT for your year, you could do reasonably well and be that person that gets 0. The chances of that happening are very, very, very so slim. Don't even consider it really. But it's based on how you score, everyone else scores, and how everyone scored in the EPM. So it's not a pass and fail exam. So I think ignore the red flag thing.
All right. If there are any more questions, should we go and do some practicing and just type your answers in the chat box for us, and we'll explain afterwards.
So this is one of your typical rank questions. So it will give you a STEM, and then it will give you 5 points, and you need to rank in order each of them from best to worst. Just be careful as well. So some of them will be rank in the order in which these tasks should be undertaken. Some of them will be rank which is the most appropriate. So just make sure that you know what you're ranking. It's most of the time it's not time based. Most of the time it's appropriateness based.
But you're also getting a good idea here of just how long the STEM is, and as a heads up, you can't take highlighters into the SJT, so I wouldn't recommend practicing with them for like key points.
Yeah, I got told off for that.
Yeah, they'll actively take anything off you that's not a pencil, so. Just throw some answers up in the chat box whenever you're done with it. Don't worry about it if you think it's wrong or you think other people have different things. It's good for us to discuss.
Yeah, I think when we had this last year, obviously we had it in person, and unfortunately we're not entitled to that lecture at the moment. But it was helpful to kind of go through things. But also it's deliberately why I've used the foundation program questions, because we had examples that were amended from the foundation program questions or made up, and actually I think it caused more confusion with some of the orders, and I didn't want to do that to you guys.
Yeah. Just asked, we can write on the question paper with a pencil, and yes, you can underline and circle and do whatever else you want to do on the question paper. Just please don't do it on the answer paper, because it will get scanned.
I'm just trying to remember how many minutes
I think they said, I thought our SJT exam was going to be on computers this year. I'm afraid we don't know anything about that, so I don't know what you guys have been told with regards to that. Dean, do you know anything about that?
I have no idea, absolutely no idea.
In that case, our comments on highlighted and pencils are irrelevant.
You know what? I do vaguely remember seeing something about that. Yeah, it might have changed actually, and then there's a thing of you could maybe do it in how you kind of do the UK CAT on your driving test.
Okay. Yeah, we're getting a few people saying that they said we'll take it in the prometric. Okay, so you're going to take it in like okay, so if you're going to take it like a driving test, then follow what they say. We're not completely up on your whatever they've said for you, so sorry about that. Just are you always in the position of an F1 for this scenarios? It should tell you who you are. I don't think this one does, but it says one of the other F1s. It should say who you are, because you will be like, you are the medical student occasionally.
Yeah, so I think that I think it was mainly F1.
Yeah.
And that's the problem with some of the practice books as well. They're like, you're the registrar. I'm like, that's jumping the gun by a few years. And you shouldn't be expected to know what a registrar day-to-day job is really, but you should know what an F1 does on the daily.
Okay, so we've had a few answers. Can we give you another minute? Can a few people just give us a few more answers so we can discuss them?
So if anyone's struggling, the key thing to do with each question is to identify the theme. So each of the themes of the question map themselves to the themes of good medical practice. So in regards to probity, communication, team working, working within your own competencies, and things like that. So kind of, if you can identify the theme of the question, sometimes that helps to identify what the most appropriate is.
Okay. We've got a few. Oh, we're having a few now. Thank you, people. Just hang on till we're like, all right. Do you want to go through it now, Dean? No, we've had we've had from various different people. We've had A, B, E, C, D, A, B, D, E, C, B, A, D, E, C. We've had a few B, A, D, E, Cs.
Okay.
We've had an A, B, D, C, E. And now we've got an A, B, C, E, D. So I don't think anybody's opted for A, B, C, D, E, which I believe is what the answer is in this situation.
Yeah. So I wanted to put this one in because it just shows that the order can be the same order that they appear in, which I think automatically throws you because you think, oh, well, they'd never do that. But it can be the case. So, yeah, kind of going back to what we were saying before, the most important thing is patient safety. If the nurse feels that there's been a medication error and she tells you this or he tells you that, then you must check it. The wrong medications can kill people, so that's really, really important. It might be nothing, but you just can't presume that. And based on the information that you were given, it's the most sensible thing to do. I think the patient beckoning you here is a tricky one, but yeah. You don't know what they're asking you for. It might be they're calling you over because they've got horrific chest pain or they're choking on something. So actually, you need to ensure that they're safe. If it then, when you get over there, it's just because they're lonely, then actually you might be able to do something else about that. But you don't know until the time, and the question hasn't told you, so you can't presume that it's nothing. Then C, so yeah, so the nurse is concerned about consistent prescribing errors. And while this is a valid concern and we're addressing it immediately with the patient that's due to have some medication shortly, we don't need to be investigating it immediately because actually it might just be a one-off. And also, as an F1, probably not going to be your role to be investigating your colleagues' prescription errors. That will probably be left to someone slightly more senior than yourself. And then finally, so spending time with the patient is desirable, but if it is just to sit and have a chat, whilst that's very noble of you and very lovely to do, and is in an ideal world what we'd all like to do if we could, well, maybe not everyone, but some people. If you've got other more pressing things to do, then unfortunately that can't be your priority at that time. There are other staff, so nursing staff, healthcare assistants, there's volunteers that come around just specifically to talk to patients. So there's other things that can be done there. So has anyone got any questions about that one?
I just want to reiterate with regards to like that last bit of E, that's why kind of, you know, if you want to take time and take histories from patients and sit with them now and hear their stories, now's the time, because when you're F1ing, I mean, I don't know how representative my time is at the moment, but I'll follow the ward round and then I catch up on all the jobs in the ward round, and that's my day. Dee's asking, how would the answer be scored, this particular one? in this specific question. So if you got A, B, C, D, E, you would get 4.
Yeah. So you'd get 4 for each of them. So you'd get 20 in total if you got A, B, C, D, E. If you got A, C, B, D, E, then you'd drop 2 marks. So you'd get 18 out of 20 because you got 2 in the wrong order, but they were only 1 out. And then, for example, if you put E first and A last, you'd get 0 for those. And then the bits in the middle would then be scored.
Is it on the question papers in the answer key? It will give you like a grid of what actual points you'll get.
Okay. Oh, apparently you couldn't see the grid, so I don't know what to do about that.
You can't see the grid, but when you come to doing your practice papers, in the answer it will have that exact explanation that we had, saying A is first because B is first because C is first because. And then there is a grid where you can basically track down, so it will tell you what you would have got if you put B in first position, what you would have got if you put B in second position, what you would have put if you had B in third. So you can work it out from that one.
Okay. So on the practice papers, that appears for all of them.
So our next question here is one of the ones where the one before we had kind of what order would you do items. This is kind of the more traditional rank in appropriateness. And you notice they use acute admissions unit and AAU in this. At the beginning of the SJT paper, they do have like a glossary. So if you are suddenly in the middle of the paper and you're like, oh, I've forgotten what AMU means, you can go back to the front and check it, because, you know, for example, IVF on my ward means intravenous fluids, and on gynae means that you're going to have a baby put in you. So very different. Okay. So you see this one's got a bit of a shorter stem, so have a little read of that. And as before, when you're ready, just chuck something in the chat box, and any questions you have about the question too. You are on it with the answers, thank you. Got a lot of ABDCs. We've got one ABDCE. Any more for any more? There's a general consensus on ABDEC and ABDCE still.
Okay, should we go to the answer?
Yeah, go on.
So the correct answer is ADBEC. And so I think most of you put A first. So yeah, as we was kind of talking about earlier, go to the first person or the area where it was affected first. You're most likely to get an answer straight away rather than kind of going around the houses. And it seems like the most logical thing to do, really. It is okay to hand over jobs, particularly if it's the end of your shift. Whilst it might not seem like an ideal thing to do, if you don't have the drug cardex or the management plan, then nothing major is going to necessarily happen to that patient. It's not great, but it's probably not hugely unsafe to hand it over to the night staff, and then you know that someone's going to do it as well. Asking the nurse in charge, so it's not really the nurse in charge's job, so you can do that, but you don't know that they're going to be able to do it or whether they'll then hand it down to somebody else. Actually handing it over to your counterpart who's taking over from your job that day is much more reliable. You can give it to your registrar, but your registrar needs to be doing their own jobs. they'll be having lots of referrals to see lots of sick patients to go and review. So actually chasing up a drug card is probably not the most appropriate job for a registrar to be doing. And then I can't read the lower bit now because the Zoom is blocking it. Can I move that now?
Okay. Yeah, but it's about the there's, if you just message the doctor on the next shift, there's uncertainty whether they will receive and act upon the message, thereby endangering patient safety.
Yeah, so basically texting someone, although it's probably what you see being done on all of the wards now with WhatsApp groups for all of the junior staff, officially it's not the most appropriate and most reliable way of informing people and asking for people to do things, even though in reality it does tend to work quite well. But for the purposes of SJT, not appropriate. Does that all make sense for everyone?
Yeah, any other questions about that?
So I'm asking these questions and I can't see the chat, so I just sit here blind. It's a very weird experience.
Just to have a little feedback. We haven't got anything. Yeah, also just to say, don't worry if you're not getting these correct. Like, you've got a little while to go before your exams. We're not expecting you to get these bang on immediately, and that you have them in the vague right order is very good.
Yeah, exactly.
Okay. No questions currently, so should we go on to the next one?
Yeah. So this one is now looking at your 3 most appropriate actions. What I would say about these ones is that it's important to realise that when you're selecting the 3, it's based on what 3 things work and should be done together. They're not individual things. Whereas the other ranking ones are separate, so they're not related at all. Whereas these ones are related. I don't know how you felt with these, Izzy, but I found it much easier to go through quickly and get rid of all the really awful ones, and then you'd be left with probably 5, and then it might be a case of working out what the 3 are. In the real thing, sometimes there was 1 or 2 questions in the real one where all of the options available were awful. No, so I don't want to do any of them, but you have to pick 3. So don't pick 2 because you'll lose marks straight away.
Yeah, there's if you're struggling to go through and think, okay, what's breaking confidentiality, what's going to take too long, what doesn't address the problem. So, like, so if you get a question about someone being depressed and not sleeping very well, telling them to go home and have a nap might deal with the sleeplessness, but it's not actually going to deal with the underlying problem. So what's actually going to solve the problem, what's going to solve it most immediately, and what also, if you're having a look at questions like these, what doesn't involve you taking on too much for yourself, because it isn't actually your problem at the end of the day, questions like these. Okay, we're getting a couple of answers already, which is nice. The other thing is, some people on the actual exam will prefer to go and do this half of the paper first, because it's the pick 3 and then you can go back to the ranking ones, which can take more time. I would say think very carefully about doing that. It's what I did, but you have to be so hot on knowing which half of the paper is which.
Yeah, I wouldn't recommend. I'd just do it in the order that the questions come in as much as you can, I think. And then if you've got time at the end, come back and review. But you probably won't have time at the end.
And you'll be so knackered anyway.
Yeah, because I think it's easier to lose your time thinking that these ones are quick, when actually, if you are pressured to do them quickly, you can get through them quickly. Whereas the ranking one, is more difficult to get through quickly if you're running out of time. And there's more of these, so you've got 47 of the ranking questions.
Got quite a few. So we've got an ADF, ACF, CDF, ACD, CDF, CFD, D16. How easy is it to complete the paper in the time given? What's your thought on that?
I found it very difficult. I was going up to the wire. I know some people though that finished early and left. Although no, you can't leave early for the SJT, but they finished and put their paper down and then left it. I wouldn't recommend doing that, but yeah, most people, I'd say, probably was struggling for time. Would you agree?
Yeah, and like I said, I rushed through the last 15 questions in 15 minutes because I was so convinced that I had enough time. It will push you. You will spend longer thinking about the questions than you want to, which is why, we've said don't overthink it and try and practice with the paper and to the timings. Because also when you're stressed, things will take longer than you think they're going to.
Yeah.
Yeah, there were some people who waltzed out and said, "Oh, I finished that half an hour ago," but I couldn't possibly. I was like rushing through it, and if I hadn't rushed through it, I would have gone through and checked it right until the very last second.
Yeah. I remember it's a very big exam. Just be sure that you're sure. But again, going back to don't overthink, but just be careful. Use your time wisely.
Also, I know a lot of people are very pro, like you do the paper, you put it down, and you don't look at it. I'm more on team, at least check it through once to make sure everything's on the right line, because if you get shifted by one line, that could change quite a lot of things. Alrighty,
Right.
so we've had quite a few answers.
Okay.
Okay,
So
there you go.
you go through it if you want. Yeah.
Okay, so DFG. So um yeah, so first, duty of care of colleagues, so you need to take care of your colleague, and towards patient and a colleague is not able to safely perform their duties. This guy is saying, I'm not sure how I'm going to cope with a weekend shift. That should probably set an alarm bell going in your head, because a weekend shift, you'll very often have less support than you would ordinarily. So it's worth talking to a consultant, because that's directly going to affect them if they're handing over jobs to an F1 or an SHO or even a Reg who doesn't feel like they can handle it. They probably need to know that, and they can kind of get involved in a safe and helpful way. Talking to an educational supervisor is really handy, because that's what they're there for. They're not there to kind of call you up on your clinical skills or say how much you're learning, although they will help you set targets for yourself. They're really there for pastoral care. So when you get into F1, it's important to make sure you have an educational supervisor you're comfortable with, and you can switch if you're not. So advising someone to talk to their educational supervisor rather than going over their head and talking to them without their permission is probably better. And then taking them somewhere private to get a full disclosure. We're really busy on the wards. There's always something going on. If you think you've got 5 minutes, if you're just doing stuff like writing TTOs, or you've got some bloods or something that can wait for 5-10 minutes, go to a wellbeing room, go to a seminar room, and have a good, chat and see actually what's going on, and help people come to the conclusions of what they need to do. There's not a clear and present danger, as it says, to patients warranting informing a senior without consent. This guy is not falling asleep. He's not drunk, which is a question that we've had. He's not actively dangerous to patients in this moment. As I said, with regards to things like him talking to his GP, how long does it take to get an appointment with a GP, even in non-COVID times? He could have a chat with his GP. He could get referred to CBT. He could even get put on some antidepressants, so if that's appropriate. But how long is that going to take? Don't use the fact that you're a doctor to ring up ITU and ask for information on a patient. People do it. You will see people ringing other wards about relatives and things like that, but don't do that. Don't be that person, because one, it's not that patient's care is nothing to do with you, and two, that guy's girlfriend's health is nothing to do with you. So hopefully those are kind of vaguely understandable. Pop any more questions you have in the box if you do.
So yeah, I think the main thing is this is looking at the immediacy, and I think with the weekend stuff, kind of as a medical student, you might not appreciate the weekend as much as when you're an F1, but I think I've certainly doing this assistantship now in the paid way that we are. I feel that I understand the weekend a lot better. It does go down to very minimal staffing, so it is a big difference, and there is an urgency in kind of sorting that out so that it's safe, really.
Yeah, I'm inclined to agree. I've had weekends where you wanted help from anyone, you had to bleep them and wait for them to get back to you. So weekends are a kind of a different time. They usually, hopefully, they're a bit quieter, but you are a bit more reliant on, bleeping senior support. There might not always be someone around. There might not always be the number of SHOs you need, stuff like that.
Okay, so this is the final one.
And then we'll let you get back to your hip hop and happening Friday nights, as I'm sure we're all having a lockdown. Also, people being abrupt in their response to you is going to be a factor of life, unfortunately, especially on the phone.
Mm.
A pharmacist 2 weeks ago asked me if I could actually count. That was a strong one. Obviously not appropriate, and everyone should be being respectful of everybody, but you have to just be aware that there's a bit of that in the job, and when you're a consultant, nobody will talk to you like that. And we're almost at the end of this lovely long chat we've had with you, so we very much appreciate you bearing with us. Hopefully it's been helpful, but there's a decent amount of stuff with the SJT which I feel like is just a bit of like arcane and weird knowledge until you have it explained to you, so hopefully we've helped with that. Okay, so we've got a BEG, a BEA, an EBG, BEC, ECG. Any more before we talk about it?
Okay, so this one is looking at how you prioritize your workload, and also recognizing when you should and shouldn't stay beyond your working day. So the right answer is BCG. So it's saying it looks at your communication and the explanation for the answer, and that's what they've put for the official thing. But actually, I think it is looking at more than just your communication, really, and it's looking at kind of the things that I mentioned as well. So you need to make sure that that patient's looked after. So although the SJT isn't testing your medical knowledge, and you don't need to know that these cardiac markers are important in terms of medically, because the question has told you that they have to be taken within the hour. So that gives you all the information that you need. So asking the person that's taking over from you is very reasonable to do. It's going to ensure that that job's done. They're the night team, and actually within an hour they should reasonably be able to do that. And then remember, with picking the three, it's what three things should be done together. So on its own, just speaking to the nurse in charge about the ward being busy and what procedures there are wouldn't address the immediate situation. But actually, as long as because you've asked your colleague to do them, then that's fixed, so the immediacy is fixed. You're then going to fix it in the long term by asking what the process is in the future if this was to happen again. And then G, you need to have a chat with that nurse. It might be that she's had a really tough day. There's been lots of things going on. So actually just the next day being like, oh, hi, are you okay? Like, I just want to talk to you about yesterday. Make sure that everything's okay is a reasonable thing to do. And often I found in the SJT as well, they prefer, if there's been a confrontation or an abruptness in someone's response, they prefer a time period being left in between you kind of raising that as an issue, as it allows people to calm down, it allows people to reflect on that situation and avoids an argument and an unwanted confrontation between two people. In this regard, so yes, there's a clinical risk that if this patient doesn't have their bloods, we might miss something. However, there should be someone that can take a set of bloods at any time within a hospital. It's not an emergency. This patient isn't dying. They're not profoundly septic or unwell. So you should be able to go home on time. There's lots and lots of people around that can take blood. Asking the nurse to explain herself and the tasks that she has to do isn't going to get you anywhere. It's just going to waste time, probably start an argument. And I think I've found that over the last few weeks, that actually sometimes it's just better just to stay quiet and let the situation do its thing, and let people vent, let people have their time, and then come back to it later. Kind of adding something in when someone's already stressed out is just not going to help at all. And then, yeah, the other ones, like I say, are just kind of confrontational really as well. So.
Yeah, I think one of the things I've got out of assistantship, and I don't know if you feel the same, Dean, is I think in your mind you have like this image of yourself as a doctor where you stay till the end. It's kind of like a Grey's Anatomy. You stay till the end, like your patients are everything, and you're chatting to them and you're personally taking care of them. And to be honest, when it gets to the end of my shift, I go and I sit down with whoever's taken over for me, and I give a really thorough handover. I give them anything they need. I pass on any jobs after I've checked what I've got, what my reg has got, what the nurses have got, and then I go home and leave it. And I try and do that as close to the time I'm supposed to be as possible. I've had people going to flash pulmonary edema and have STEMIs and whatnot, and I've stayed later. But if not, then it's kind of I hand over at a good time and I leave, because that's what you're going to have to do for the next X number of years.
Mm-hmm.
And it's good to get into a habit now than to say it. I always hate saying it's kind of like, oh, when you have children, but in the future you may need to have things that you need to leave bang on time for that you don't have now. So it's good to get into the habits now.
Yeah. So all the practice questions that we've got for you. I didn't want to bombard you and overload you with practice questions on a Friday night, really. So I hope that kind of gives you a small insight into what the SJT is like, and I hope we've helped to relieve some fears, answer some questions that you had, and generally just provide an overview. We're more than happy to answer questions that you have now, that you were hoping that we would address and that we haven't, or any question really in regards to what we are up to now, how we found the application. I know that other people have touched on these things as well, but more than happy to answer questions in regards to anything you have for final year really, because I know that sometimes it's nice to have a range of views, but equally, if you just want to leave and don't have any questions, it's also fine.
Yeah, by all means, run off if you want to, and have a lovely evening, because part of the thing that we've been saying is you need to, you know, take care of yourselves, take care of each other, and have rest. But if you've got any questions about like final year FP, AFP, finals, assistantship, etc., yeah, we very much appreciate you all being here and you all turning up after your busy weeks. How did we revise for the PSA? Don't apologise. We are quite happy to answer anything you want to answer.
Yeah. PSA. When you say that, do you mean the national one or do you mean the Warwick one?
I'm assuming she means PSA, not the WPS, but
yeah. What did I do? I left it until all other finals were finished.
Correct, yes.
And then by that point, I didn't care anymore. It's probably not what you want to hear, Yasmin. I apologise, but I think I speak for most of our cohort when we got to that point, and we had nothing left. You're exhausted by the time you get to your PSA. We were also in the point of trying to salvage what might be left or not left of the elective, and then straight after the PSA was done, we got told that we weren't going on elective. So I
was to say that was the same bloody day, wasn't it?
So there was a lot of other things going on. So actually, my revision for the PSA was not as good as I would have liked it to be. But saying that, I don't think you need to do lots. I think what you need to do is the practice papers online again. Get used to the timing. The PSA is even more time pressured than the SJT. You have to answer things very, very quickly, and get used to using the online BNF. So using your Control F is key. You can use it in Warwick. You can't use it in some other unis. So we do have a slight upper hand. Whether that changes for next year, I don't know, but I can't see it will. And yeah, get used to where everything is in the BNF. So where you find information about overdose, where you find information about warfarin, how you can quickly find up drug interactions, because that's all the basis of your PSA. Really.
Yeah, you have medicines complete in the PSA, which I think is incredibly helpful.
Yes, I could use that more.
Yeah, Rodney. Yeah, so you have the practice PSA. I actually think is very helpful, and kind of gave me a rough idea of where I would struggle. But I would say that the RPSA was slightly more difficult than the practice, because for some reason it was all like gentamicin and aminophylline dosing.
Yeah.
Which was really mad. The PSA is not too difficult. There will be obviously stupid answers. The thing to look at is just to kind of figure out do the practice one, maybe do a little bit of having a look at, again, there are practice papers online, there are questions on PassMed if you're a PassMedder. Do a little bit before the practice paper, not a huge amount, and I would say use your practice as your baseline for what you need to sort out going from there, because I was like, my calculations are taking me too long. Can I do anything about that? Had a good go. I was so knackered by the PSA. I don't think they'd gotten any fast.
Yeah. And don't worry about it for the time being. Like, it doesn't need that much. And I'm more than happy to go through a drug card with you. Me and one of your colleagues actually were going through one for gentamicin, because it was prescribed at the patient's body weight rather than their ideal weight. So knowing things like that as well, and knowing where to find them. So like gentamicin, once you get above a certain weight and a certain BMI, you have to prescribe it by ideal body weight rather than actual body weight. So just being aware of those kind of little things.
I'll be honest with you, by that point, everyone was thinking about the pub was the PSA, and with all of our electives going tits up. Yeah.
Oh no, we were allowed to go that night, but up after that we weren't.
Yeah, yeah, it was. I think to say that I was very stressed about the whole elective thing because mine had just like, I mean, yours and mine was very similar, Dean, but mine had just gone completely out the window, and I still got a very decent score on the PSA. I wouldn't get too wound up about it. There
Yeah.
is some stuff floating around the internet that's like, actually it's a very difficult exam, and it's scary. The WPS and being able to flip through the BNF, I think, is more intense than the PSA was.
Yeah.
Any more questions before we go with our last remaining few? Or if not, go and enjoy your evenings and do some socially distant wandering. Have socially distant snacks, drink socially distant beverages. We're getting lots of thank yous and appreciation, so just
No
passing
worries.
that on to you.